Hi and welcome to another ICS Impulse video. I'm Wendy Crumley-Welsh, the product manager for ICS Impulse. And today we're talking about the dynamic positional tests. Dynamic positional tests provide the ability to diagnose BPPV, or benign paroxysmal positional vertigo. The purpose of this test is to identify nystagmus that is evoked from dynamic changes in the patient's body orientation with respect to gravity, and thus diagnosing BPPV. Different positional tests are used to assess anterior-posterior canal BPPV or lateral canal BPPV. We are going to be talking about several different positional tests. We're going to talk about Dix-Hallpike, Hallpike-Stinger, and Roll. Now, posterior semicircular canal BPPV is the most prevalent. So, first one is Dix-Hallpike. This test assesses the anterior and posterior semicircular canals by recording the patient's eye movement during the maneuver. The ANSI standard, or American National Standards Institute, recommends that this test be performed with vision denied. I also want to mention that the British Society of Audiology also has a recommended procedure for the Dix-Hallpike. So the patient is sitting, and as we go through this, as I'm talking through how the test is performed, we're going to show you a video of a patient actually being positioned into these different positional tests. So the head is turned 45 degrees to the left or the right, depending on which side is being assessed. The patient is quickly laid back with the head slightly hanging off the end of the exam table. The patient's head is comfortably supported by the examiner during the test. According to the ANSI standard, the eye should be recorded for a minimum of 20 seconds in this position. And it's best to continue recording the eye movement until the nystagmus subsides. So you hold the patient down in this position until the nystagmus stops. Or if there's no nystagmus, you would record for a minimum of 20 seconds. Then the patient is brought back up to the sitting position, and again the eye movement should be recorded until the nystagmus subsides. The next test, the Hallpike-Stinger, is very similar to the Dix-Hallpike. So again, you would turn the head 45 degrees to the left, bring them down, or 45 degrees to the right and bring them down. What's different about the Hallpike-Stinger is that you have an additional position, which includes having the person centered, and you bring the head straight back towards the examiner with the head hanging off the edge of the table and the patient facing straight towards the ceiling. A third option is side-lying. Side-lying is actually a modified Dix-Hallpike. So you use side-lying when the patient has a range of motion limitations or other problems precluding you to use the Dix-Hallpike maneuver. So again, this assesses the anterior and posterior semicircular canals by recording the patient's eye movement during the maneuver. So just like Dix-Hallpike and Hallpike-Stinger, side-lying is assessing the anterior and posterior canals. The patient is sitting. The head is turned 45 degrees to the opposite side of the affected ear, so leftward or rightward. The patient is laid on the side of the affected ear, and the nose is turned 30 degrees in the opposite direction. So the nose is kind of turned up towards the ceiling. The next test is the Roll test. This one is unique because it assesses the lateral semicircular canal, and again you're recording the patient's eye movement during the maneuver. You start with the patient laying supine, and you have the head tilted up 30 degrees. Then you quickly turn the head towards the affected side 55 degrees, or as far as it will turn to the left or the right, depending on which side is being assessed. So the minimum is 55 degrees, the maximum would be 90 degrees, but you want to turn the head as far as it will go to the side. So again, patients laying supine, you quickly turn the head to the left or to the right side. The patient's head is comfortably supported by the examiner during the test. The eyes should be recorded for a minimum of 20 seconds in this position. Again, it's best to continue recording until nystagmus subsides. Then the patient is brought back to the supine position, and the eye movement again should be recorded if any nystagmus is present until it subsides. Regarding pupil detection, calibration, or the vision denied solution, these are all covered in separate videos. Regarding goggle placement, you want to tighten the goggles so they stay put during the maneuver, but they do not need to be as tight as head impulse testing. You just want to make sure the goggles do not move during movement of the patient or the patient's head. Regarding the eye video recording, when you are doing pupil thresholding, you have the option of grayscale image or pupil location, but note that no matter which one you choose, the eye video will always be recorded in grayscale. And then head position feedback or synchronized room video. We're going to show you head position feedback, and the reason why that's bold is because that's what I think is most useful. The head position feedback will actually help guide you to make sure that patient is positioned at the proper angle. If there was a test that you wanted to perform that wasn't in this list, then I would use the synchronized room video to video the patient. And then the last two things, the external monitor and the presentation remote. So if you click this button, external monitor, you can then put the eye up on a big external monitor, which is helpful when you're maneuvering a patient leftward and rightward. You could have your laptop on one side of the table, a LCD monitor on the other side of the table so that you could monitor the eye. Again, you don't want to move to the next position until that nystagmus subsides. The other thing that'll be up on that external monitor besides just the eye video is the real-time SPV number. So that will also help guide you to make sure that you continue to keep the person in that position until that nystagmus subsides. The presentation remote I think is very helpful when doing positional testing. This allows you to start and stop the test without having to be near the computer. So it's just a simple little presentation remote. You can push the left button, right button to start and stop the test. So let's show you in software how to select these tests. So over here in the left is your navigation panel, and you're going to want to go to the positional module and go to dynamic. Now in dynamic you have four options: Dix Hallpike, Hallpike Stinger, side lying, and roll. Under Dix Hallpike you want to choose whether you're doing this test with vision or with vision denied. Now remember, if you start off with a Dix Hallpike or one of these other tests, you need to make sure you calibrate, and you want to do that without having vision denied checked or the vision denied solution on. Otherwise, if you're doing the test and you want to make sure that you have vision denied, you use the vision denied solution and you check this box here. Then you have a drop down. For Dix Hallpike you have head left, repeat, head right, repeat. Hallpike Stinger, you have three options: head right, head straight, that's that straight back maneuver, and head left. Side lying, you have leftward and rightward. And then roll, you have leftward and rightward. So when you get ready to collect data, you want to instruct the patient. So you want to let them know what's going to happen to them. A lot of times you want to have the patient cross their arms in front of them so that they feel secure, they don't feel like they're falling, and you don't want them to flail. So you can cross their arms across their chest and then lay the patient back. The next thing is the real-time SPV. So on the screen you'll see a trace. The red is the horizontal eye position trace and the purple is the vertical eye position trace. So here you see the SPV, real-time SPV number. If it's green, that means that the eye movement is very consistent. If it's orange, that means that eye movement's moving in several different directions and it's not very consistent, which would not be the case in nystagmus. So it kind of gives you a reliability check if that patient's doing what they're supposed to be doing. And then up here in the collection window, I want to show you the head position feedback. So the first thing you do when you're starting your data collection is you have the person either lying down or sitting down. You center their head, or if the maneuver says that that head is tipped 30 degrees, then you tip the head 30 degrees and you hit the center button. That center button is basically a zero reference point. That's your starting point. And then you'll see these different angles. Now this is an example of Dix Hallpike. So here it also highlighted in green are the canals that you're testing. You're turning the head 45 degrees. So as you turn the head 45 degrees, the little blue ball should match up with the line. So that's step one. And then when you bring the patient backwards, that ball will then hit step two when you're positioned properly. So we're going to show you a video of a Dix Hallpike. You know, you just saw the video of the live maneuver, but now we're going to show you the video as well as some test data showing you the Dix Hallpike maneuver and the head position feedback. The head position feedback we find is a very unique feature and very, very helpful. to make sure that the patients are being positioned properly. And the other nice thing is then you can also play back that head movement as well as your eye video, as well as your traces and your SPV graph. So let's show you a Dix-Hallpike first. You have the patient sitting up, have them turn the head 45 degrees, and then you bring them back. And the next one we want to show you is the Hallpike Stinger, but for this one we're just going to show you the bringing the head straight back, because the right and the left are exactly the same as Dix-Hallpike. And then lastly, we want to show you roll. So the patient is supine with their head tipped 30 degrees, and then you move the head to the left or to the right 55 to 90 degrees. So you'll see in the head position feedback there's a block, and your ball just needs to be within that block. The top line, the upper line is 55 degrees, the lower line is 90 degrees. Okay, now data analysis. Now this is a roll test, and this patient had a normal response, but as you see here, you have the horizontal trace, the vertical trace, and then the beats, and the beats are all 0. So this patient did not have any nystagmus during the roll test. Now let's talk about playback, and let's actually go to this patient file and play this back. Okay, so here you see that we're in a roll rightward test, and we hit play. It's going to play the trace, the SPV graph, the eye, and the head movement all together. And we're going to play this at normal speed. So we tipped the head, we moved her. So she's moved actually to only 55 degrees, and then brought back up. And we don't have any nystagmus. You can also play this in slow motion. So if you click slow, okay. And then the other thing to note is that you can actually start the video anywhere you want to. If I want to start the playback right here, and note that wherever I click, the eye video matches up with the head video and matches up with the SPV. But if I say I want to play from cursor, then I can just play this last end of the trace. So you have several options for playing back, but everything plays back synchronously. So in the info tab, it tells you the test type. So it's roll, it was rightward, vision denied, the operator, the calibration, test time and date, how long the test was, the elapsed time, the analysis begin time. So in that trace that I showed you, the full trace was analyzed, so the analysis begin time is 00. But let's say that when I moved the patient, I had a big blip or something that I didn't want included at the beginning. Then I could set my cursor and choose where I want that analysis to begin. And then the begin time would be different than 0. The peak SPV, so 2 degrees and -5 degrees, and that's nothing significant. And then beat SPV, if I click on a particular beat, that tells me that particular beat's, how many degrees it was and at what seconds that beat occurred. We've already gone through a positional test, but here again, you'll have the list of date and times, all your tests. If they were collected with vision denied, the vision denied will be checked. And if you put in any remarks, you can put them under the remarks tab here, or you can type them in here, but any remarks for that test would be visible here. And then the last thing, which we kind of talked about, is reanalysis, the reanalysis tab. So you can choose where analysis starts. If you want to analyze the full trace, you click reanalyze full trace. Or if you just want the analysis to start at a particular point, you set that cursor on your trace and you click reanalyze from cursor. You can also delete beats, you can restore deleted beats, and you can change where the peak was selected, and you can restore the peak. Do note that you need to make sure you select the right curve when you're looking at your data. This is the horizontal right curve and vertical right curve. So you need to make sure to select the curve and then do the reanalysis here. When you have existing patients in your database, so here you have a patient, and then you've got these little icons. Now if a dynamic positional test was done, This little icon here showing a little figure with his head below the table is the positional icon. So any dynamic positional test would then result in a check next to that patient's name. So as long as you have dynamic positional tests saved for that patient, then you'll have a check mark in that column. So let's talk about dynamic positional interpretation. Abnormal dynamic positional test represents peripheral dysfunction and is indicative of the presence of BPPV, or benign paroxysmal positional vertigo. What happens is a burst of nystagmus that is provoked by the head movement. It's usually delayed in onset. That means that you position the patient down so their head's hanging over the edge of the table, and it usually takes a second or so before the nystagmus starts. So it's delayed in onset, and then it's usually a burst of activity, meaning that then it becomes more robust, and then it finally fatigues or subsides after time. Then when you sit the patient back up, sometimes you'll see a direction reversal on when the patient is sitting up. So the nystagmus is typically torsional. So again, when you sit them back up, it would reverse. The torsion would reverse direction. The other thing to note is that if you do the test a second time, usually the nystagmus is not as robust because, again, it is fatigable. Most BPPV, again, is evidenced by torsional eye movements. Posterior canal BPPV is most prevalent. Horizontal canal involvement is less common and typically results in horizontal nystagmus. So purely horizontal nystagmus is usually lateral canal or horizontal canal BPPV. And BPPV is commonly unilateral. It's not as common to have bilateral BPPV.